Welcome to the Hospital Medicine Unplugged podcast.
Glad to be here.
Today, we are undertaking, a really critical deep dive into an electrolyte abnormality that, let's face it, defines a huge chunk of our daily workflow.
Absolutely.
We're talking about the evidence-based clinical management of hypokalemia in the hospitalized setting.
And it's just so common. This is more than just chasing a lab value. It really is foundational inpatient care. Hypokalemia, that's serum potassium below 3.5 millimoles per liter, it affects, over 20% of our admitted patients?
The least. And even when it seems mild, maybe just below 3.5, the link with significant morbidity, it just demands a high level of clinical rigor from us. So our mission today really is to cut through some of the maybe institutional inertia, those protocols that might be based on older assumptions.
Yeah, the old 10 gives you 0.1 rule.
Exactly. We need to distill the current guidelines, look closely at some of the enhanced diagnostic strategies, and maybe most importantly, tackle the reality of potassium repletion dosing and, the surprisingly frequent monitoring lapses we sometimes see.
That's a big one. So maybe let's anchor the discussion first, just confirming the definition and critically understanding the risks, because the risk really dictates how urgently we need to act.
Good starting point. So, definition. Hypokalemia starts at that 3.5 millimoles per liter threshold.
Right, 3.5. And then we classify it, don't we?
We do. Mild is generally considered 3.0 to 3.5 millimoles per liter. And you're right, in this range, patients are often asymptomatic, but the risk clock is definitely ticking, especially if they have underlying heart issues.
Yeah, you can't ignore it even then.
Yeah.
Then moderate hypokalemia runs from, say, 2.5 to 2.9 millimoles per liter.
And this is where you start seeing symptoms more often, right? Mild weakness, maybe just feeling generally unwell.
Exactly. And then we hit severe territory that's anything less than 2.5 millimoles per liter. And at that point, it's immediate action, often pretty intensive.
The second that number dips below 3.0, really, the siren sounds in my head. And that's entirely because of the cardiac risk.
Absolutely. It's the most serious clinical manifestation. It's driven by that increased cardiac excitability, the prolonged repolarization phases.
Which leads to a significantly increased risk of complex arrhythmias. We're talking atrial tachycardia, ventricular tachycardia.
And potentially ventricular fibrillation. It's life-threatening.
And that risk isn't spread evenly, is it? It's dramatically worse in certain patients we see all the time.
Oh, definitely. Patients with underlying cardiovascular disease, anyone with heart failure where contractility is already iffy.
And critically, any patient taking digoxin. That interaction is classic.
It really is. Hypokalemia just potentiates digoxin toxicity. It competes for the binding site on the sodium-potassium ATP Ease pump, so you get enhanced digoxin effects and way more cardiotoxicity.
So we have to be really vigilant about the ECG findings. What are the classic signs we look for?
Well, the characteristic fingerprint, includes T-wave flattening. That's often the earliest sign you see.
Right.
Then ST segment depression and the appearance of those prominent U waves.
But the one that really makes you nervous, the precursor to the bad arrhythmias, is QTC prolongation.
That prolongation is absolutely key. It's what sets the stage for torsades de pointe. When potassium is low, cardiac repolarization slows down. It increases the sort of dispersion of refractoriness across the heart muscle.
Creating that perfect substrate for reentry arrhythmias. Nasty stuff.
Very nasty.
And beyond the heart, severe hypokalemia hits the neuromuscular and GI systems pretty hard too.
Yeah, patients might present with just non-specific generalized muscle weakness, maybe cramps.
But if it progresses,
then you can see flaccid paralysis. And in really profound cases, often below 2.0 millimoles per liter, you worry about respiratory muscle involvement.
Which is an immediate emergency. Requires airway management, pronto.
Absolutely. And the GI symptoms, paralytic ileus is a big one. It causes patient distress, obviously, but it also complicates recovery, nutrition, extends the hospital stay.
It really messes things up. And then, while it's rare, the most profound cases can actually lead to rhabdomyolysis.
Right, because that potassium gradient is crucial for normal muscle cell membrane stability. When you lose that gradient, cells get injured, they break down.
What's really crucial, I think, for us to emphasize to our colleagues is that you shouldn't wait for these really dramatic symptoms. The evidence is crystal clear. Even mild hypokalemia increases overall morbidity and mortality.
That's such an important point.
And furthermore, the adverse outcomes don't just correlate with how low the potassium gets, the absolute nadir, but also with how fast it drops.
Right. The rapidity of the decline matters hugely.
A sudden drop, say from 4.5 down to 3.0 in just 24 hours, that can be way more symptomatic and dangerous than someone who's chronically sitting at 3.0.
That speed of change just mandates immediate proactive management. You have to tailor it to the rate of loss.
Absolutely. So if the clinical picture is the what, then understanding the why, the underlying pathophysiology, that's the only way we stop this from happening again and make sure our replacement actually works.
Exactly. Let's dig into potassium homeostasis a bit.
Okay.
So potassium homeostasis, it's this really finely tuned system. It involves balancing external factors like intake versus excretion.
Mostly renal excretion, some colonic too.
Right. And then balancing that with internal factors, mainly those transcellular shifts, moving potassium between the huge intracellular reservoir and the much smaller amount in the extracellular fluid.
And in the hospital, we generally see, three main buckets of causes? The first one, by far the most common in my experience, is increased losses.
Agreed. Increased losses are number one, and you can divide those into renal and extrarenal. The renal losses, often iatrogenic, right?
Oh yeah, diuretics.
Yeah.
Loop diuretics like furosemide, thiazides like HCTZ, they're major culprits.
They work by increasing sodium and water delivery down to the distal nephron, which then forces more potassium secretion through channels like the ROMK channel.
And we also have to think about non-drug-related renal losses, things like mineralocorticoid excess states.
Right. Hypoaldosteronism, whether it's primary or secondary, or Cushing's syndrome. The excess mineralocorticoid directly stimulates potassium excretion.
And then there are the sort of classic but less common tubular disorders, Bartter syndrome.
Which kind of mimics loop diuretic use, affecting the thick ascending limb.
And Gittleman syndrome.
Which mimics chronic thiazide use, affecting the distal convoluted tubule. And sometimes recognizing the pattern, like hypotalsuria and Gittleman's, can help you differentiate.
Good point. Okay, moving to the extrarenal or GI losses, what are the big ones there?
Vomiting, chronic NG suction, high output diarrhea, and laxative abuse are all common things we see in the hospital.
And there's a key distinction with vomiting, isn't there?
Yes. While you lose some potassium directly in vomit, the bigger issue is losing hydrochloric acid, which causes metabolic alkalosis.
And that alkalosis drives potassium into cells.
Exactly. Plus, the kidney tries to conserve volume because of the dehydration, which often leads to this paradoxical wasting of potassium in the urine. Even though the patient is total body depleted, it's complex.
That complexity nicely bridges us to the second main bucket, transcellular shifts.
Right. And in these cases, the total body potassium might actually be close to normal, but the patient is profoundly hypokalemic just because all the potassium is temporarily hiding inside the cells.
Recognizing this is so critical because the management is totally different than replacing an actual total body deficit.
Absolutely. What are the common drivers in the hospital setting? Insulin is a huge one.
Yeah, if you give aggressive glucose, the insulin response activates the sodium-potassium ATPase pump, pulling potassium rapidly into cells. Think DKA treatment.
Or think about our pulmonary patients.
Yeah.
Beta-2 adrenergic stimulation, maybe from stress, but more often from nebulized albuterol.
Right, that pushes potassium into cells too. And just plain old alkalosis, whatever the cause, facilitates this shift by swapping hydrogen ions out of cells for potassium ions moving in.
And then finally, the third bucket, which is decreased intake. It's usually more of a secondary factor, but you can't completely ignore it.
Especially in patients with severe malnutrition, chronic alcohol use disorder, or maybe someone who's been NPO for a long time without adequate parenteral nutrition. Lack of input definitely makes ongoing losses worse.
For sure. So the crucial point here is figuring out where the potassium is going. Is it being lost from the body or just shifted into cells?
Which takes us straight into the diagnostic evaluation protocol. And that has to start with a really meticulous history and exam.
Indeed. Back to basics first. Detailed history, focusing intensely on that medication review, diuretics, steroids, certain antibiotics, laxatives, herbals even, quantifying any GI losses.
Assessing volume status, blood pressure.
Then the standard labs, serum electrolytes, renal function tests, and looking at the acid-base status.
But here's where we need to go beyond just the serum potassium value. The absolutely critical step is using urine measurements to tell renal wasting apart from extrarenal loss.
Exactly. If the kidneys are doing their job and trying to conserve potassium appropriately, That points towards the loss happening outside the kidney.
So we're looking for the kidney being, as you said, a responsible citizen. How do we check that?
Extrarenal loss, typically GI loss or maybe just poor intake, is strongly suggested if you get a spot urine potassium concentration that's less than 20 millimoles per liter.
Okay.
Or, alternatively, if you do a 24-hour urine collection, less than 20 millimoles total excretion also points away from the kidney being the problem.
And if the urine potassium is above those thresholds, say 30 or 40 millimoles per liter?
Then that signifies inappropriate renal potassium wasting. The kidneys are still dumping potassium even though the body is systemically deficient. That's the key distinction.
So for those complex cases, especially when the spot urine potassium is high, we sometimes need more advanced urinary indices, right? Though we have to be realistic about using them in acute practice.
We were all taught about the fractional excretion of potassium, the FEK.
Requires plasma and urine potassium and creatinine.
And the transtubular potassium gradient, or TTKG.
Which is physiologically elegant. A TTKG greater than 3 suggests renal loss.
But the TTKG, it requires simultaneous plasma and urine osmolality measurements to correct for water reabsorption. That often makes it impractical or just too slow to calculate when you need the answer right now, like at 3 a.m.
Yeah, getting simultaneous accurate osms isn't always straightforward on a busy floor. This is why some of the newer evidence, focusing on indices using readily available spot urine labs, is so interesting.
Exactly. We're starting to see more about the practicality of ratios like the urine potassium to creatinine ratio divided by the serum potassium squared, the UKUCR over SK squared ratio.
What's the advantage there?
Well, what's fascinating is that this newer ratio seems to offer pretty high diagnostic accuracy for identifying renal potassium loss. It often correlates quite well with the TTKG, but without needing those pesky osmolalities.
So it gives us a more practical, reliable tool maybe to confirm if we're dealing with a diuretic effect or a tubular issue, or maybe just volume contraction driving the loss.
Potentially, yeah. It's promising. And of course, if the history and labs are really pointing towards a mineralocorticoid-driven mechanism like refractory hypertension, maybe metabolic alkalosis too,
then you have to go further with targeted assays, measuring plasma renin and aldosterone levels to really nail down the driver of that chronic renal wasting.
Right. The diagnostics really are the map that has to guide the management.
Okay, so let's move into management. The first principle, the foundational one, which, sometimes we overlook in the rush to just order KCL,
is identifying and correcting the underlying cause. It sounds obvious, but
it's huge.
right.
If you don't stop the ongoing losses, whether that's adjusting a diuretic, treating the diarrhea, addressing the alkalosis, your repletion efforts are just going to be constantly playing catch up. It's frustrating.
Totally frustrating. You can pour in high-dose potassium, but if the patient's simultaneously getting a continuous furosemide drip, that potassium is just going right back out. You'll be reordering the same dose in 4 hours.
Exactly. So once the source is addressed, then we select the route and the dose based on severity and the patient's overall clinical status.
Right. So for mild hypokalemia, that 3.0 to 3.5 range oral replacement is definitely preferred, assuming the GI tract works and the patient isn't acutely ill.
And the dose is usually manageable, right?
Yeah.
Like 20 to 40 millimoles per day,
Orally.
plus maybe some dietary advice.
Yeah, typically. Now, moderate hypokalemia, 2.5 to 2.9, that usually needs a bit more of an assertive approach.
Oral is still the first choice if they can take it.
Generally, yes, but at a higher total dose. Often 40 to maybe 100 millimoles per day, usually in divided doses to help with GI tolerance.
But if the patient is symptomatic or has ECG changes or just can't take anything by mouth,
then you have to switch to intravenous potassium chloride. And we generally start at a rate of, say, 10 to 20 millimoles per hour.
Okay. And then for severe hypokalemia less than 2.5, or for any patient who's clearly symptomatic, like significant weakness, or definitely if they have an arrhythmia.
IV replacement is mandatory and urgent, no question.
Now, we absolutely have to talk about the practicalities and the safety limits of IV potassium. This is where institutional protocols are just so critical.
Absolutely. The general infusion rate peripherally is strictly limited, usually 10, maybe up to 20 millimoles per hour maximum through a peripheral line.
And if you feel you need to go faster than that,
then you hit a hard stop. A maximum rate of 40 millimoles per hour is really only permissible in an ICU setting with continuous ECG monitoring and often requires specific physician oversight or sign-off.
Right. And crucially, infusions greater than 10 millimoles per hour absolutely require central line access, period.
That access point is non-negotiable for higher rates. Potassium chloride is just too irritating to peripheral veins. You get phlebitis, pain.
And potentially tissue necrosis if it extravasates. If you try to run 40 per hour through a peripheral PIV, you'll just be replacing the IV and ordering pain meds constantly.
It's just bad practice. And another safety point that cannot be stressed enough: never, ever administer potassium in glucose-containing fluids like D5W.
We still see this protocol error sometimes, unfortunately. Why is it so bad?
Because the glucose triggers insulin secretion. And as we just talked about, insulin drives potassium into cells via that transcellular shift.
So it transiently, but dangerously, worsens the serum hypokalemia. You're essentially neutralizing the effect of the very replacement fluid you're giving.
Exactly. It's counterproductive and potentially harmful. Always use saline or another non-glucose solution.
Okay, moving beyond just the safety rules, we have to talk about the dosing reality check. This feels like one of the biggest paradigm shifts in recent years.
It really is. We were all taught that old rule of thumb: 10 milliequivalents of potassium chloride raises the serum potassium by 0.1 millimoles per liter.
Yeah, ingrained in us during residency.
But that traditional rule, honestly, often leads to underdosing. Recent studies, both retrospective and prospective, just don't consistently support that one-to-one expectation, especially not in patients with acute ongoing losses.
So what does the data actually show?
The median increase observed is often only about 0.05 millimoles per liter for every 10 milliequivalents given.
Wow, that's half. Half of what we expected.
Exactly. And this is so crucial when you're guiding stat repletion orders. If you order 20 milliequivalents thinking you'll get a 0.2 bump, but you only get 0.1.
You've undertreated, and the patient stays at risk longer.
Precisely. This newer data forces us to accept that we often need to give much more, maybe 40 to 60 milliequivalents, just to achieve a minimal one-step correction, especially if the starting deficit is significant.
And this lower than expected response, it gets even worse with certain coexisting factors, right?
Oh, definitely. We absolutely have to highlight the blunting effect of concomitant loop diuretics.
Yeah, if a patient is actively peeing out potassium because of furosemide, you're essentially replacing it while they're simultaneously losing it. One step forward, one step back.
It means you need higher overall cumulative doses, or you need to think about adding adjunctive agents to slow down that ongoing loss.
Which brings us perfectly to adjunctive therapies. If you're faced with refractory hypokalemia, the potassium just won't budge, despite giving what feels like tons of KCl. What's the first non-negotiable step?
Check magnesium and correct it.
Always. Hypomagnesemia is potassium's evil twin, right?
Basically, yes. Magnesium deficiency directly impairs the kidney's ability to reabsorb potassium. That magnesium ion is needed for the ROMK channel in the distal tubule to function correctly and hold on to potassium.
So without enough magnesium, that channel just keeps leaking potassium.
Pretty much, making it almost impossible to correct the hypokalemia until you normalize the magnesium level. So, bottom line, in any severe or refractory case, always check and correct the magnesium first. It's often the key.
Good advice. We also need to be thoughtful about which potassium salt we choose, because it can impact the patient's acid-base status.
That's right. Potassium chloride, KCl, is the preferred salt in most situations. Why? Because hypokalemia often goes hand in hand with chloride loss too. Think about vomiting, diuretic use. They cause a hypochloremic state as well.
So KCl replaces both deficits. Makes sense. But what if the patient has an associated metabolic acidosis?
Then using potassium chloride would actually worsen the acidosis because chloride is an acidic anion, essentially. In that scenario, you should opt for potassium bicarbonate or potassium citrate.
Because those convert to bicarbonate in the body.
Exactly, and they help buffer the excess acid. Similarly, if you have coexisting phosphate depletion, which is common in alcohol use disorder, refeeding syndrome, TPN patients, then potassium phosphate should be your choice.
Right, repleting both electrolytes simultaneously. Okay, and what about those long-term cases? Patients with ongoing persistent renal potassium wasting, like the diuretic-dependent heart failure patient, or someone with a known tubular disorder.
For those situations, you need strategies to minimize the loss itself. This usually involves adding a potassium-sparing diuretic to their regimen.
Like spironolactone or eplerenone or amiloride?
Yep. Those agents work in the distal nephron to decrease potassium secretion, helping to counterbalance the losses from other causes.
Okay, so once we've started the repletion, rigorous monitoring is absolutely essential, and the frequency needs to be tailored. This feels like another area where protocols sometimes fall short.
Agreed. Lack of specificity in monitoring protocols is common. for mild asymptomatic hypokalemia being treated orally.
Rechecking serum potassium within 24 hours is probably reasonable, just to make sure your oral strategy is working.
Yeah, generally sufficient. But for moderate or severe cases, anything like 2.9 or below, or for any patient getting IV repletion.
Then you need mandatory reassessment much sooner, right? Every 2 to 6 hours during active replacement.
Absolutely. Every 2 to 6 hours while you're actively infusing or giving large oral doses. And that needs to continue until the level is confirmed stable in the normal range. Then you can maybe back off to daily checks.
And when do we absolutely need continuous cardiac monitoring?
Definitely recommended for all patients with severe hypokalemia, any symptomatic patient, regardless of the number, or if that IV rate goes above 10 millimoles per hour.
Just because you're actively giving a potentially dangerous substance directly into the bloodstream. Makes sense.
Exactly. Now, turning to special populations, we really have to individualize therapy. A quote-unquote normal potassium level isn't necessarily the optimal target for everyone.
Good point. Take the heart failure patient or someone on digoxin. They're just so susceptible to arrhythmias, even at levels we might consider only mildly low in other patients.
For them, the target is often higher. You're usually aiming for a serum potassium greater than 4.0 millimoles per liter, maybe even closer to 4.5, just to provide that maximum protection against digoxin toxicity or ventricular irritability.
Okay. Conversely, what about patients with chronic kidney disease, especially stage 4 or 5?
Extreme caution is needed there. Their kidneys just can't handle potassium, normally decreased GFR, often impaired tubular secretion too. This puts them at a much higher risk of developing subsequent iatrogenic hyperkalemia from our treatment.
So they need much more frequent monitoring and probably lower total repletion doses spread out over more time.
Definitely. Always check the eGFR before you order large potassium loads in anyone, but especially in CKD patients.
And as we touched on earlier, those concomitant medications that actively drive potassium loss,
Loop diuretics, corticosteroids, even things like high-dose penicillin derivatives, which can act as non-reabsorbable anions in the urine.
their presence just necessitates adjusted, usually higher, initial repletion doses to counteract that ongoing pharmacologically induced wasting.
And we just have to remember that multifactorial hypokalemia is really the rule, not the exception, in acutely ill hospitalized patients. You've got to look for and correct all the coexisting electrolyte disturbances, especially hypomagnesemia, but also things like hyponatremia to really achieve stable normokalemia.
Correcting sodium too aggressively might affect volume status and mask ongoing potassium losses, for instance.
Right, it's all interconnected.
We also have to talk about the complications of our treatment, because sometimes the cure can be as dangerous as the disease itself. Iatrogenic hyperkalemia is the big one.
It's the most serious complication for sure, especially if we give IV potassium too rapidly or if we fail to recognize underlying renal impairment.
And this overcorrection, it can lead to life-threatening arrhythmias too, just on the other side of the spectrum. Ventricular fibrillation, even asystole.
Tragically, yes, which just highlights again the absolute necessity of those strict rate limits, 10 to 20 per hour peripherally, max 40 in the ICU, and drawing those recheck labs reliably in that 2 to 6 hour window.
Overcorrection often happens when people rush the dose or just forget or delay getting the follow-up lab.
Exactly. Now, even with oral repletion, there are some things to consider, while generally very safe now.
We should remember that some older, slow-release tablets, particularly the ones using a wax matrix carrier.
Right, those were historically associated with rare but serious GI problems, ulceration, stricture formation, bleeding.
Which is why the microencapsulated preparations are generally preferred now, correct?
Yes. They tend to dissolve more uniformly throughout the GI tract, which mitigates that risk of having a really high, localized concentration of potassium irritating the gut mucosa.
Good to know. And we also need to be aware of potential rebound effects, right? Like rebound hyperkalemia.
Yes, there's definitely a risk of swinging too far the other way, especially after you've corrected the initial problem, particularly if the cause of the hypokalemia was transient.
Like what kind of situations?
Well, think about patients getting aggressive eution. TPN rapid shifts can happen when you stop it, or patients with certain hematologic cancers undergoing rapid cell lysis during chemotherapy.
So the potassium that was inside the cells comes rushing out.
Or if the initial cause was an acute shift, like after that severe albuterol treatment example, if you aggressively replace potassium for that, once the beta-2 effect wears off, the potassium shifts back out of the cells, potentially causing rebound hyperkalemia. The pendulum can swing fast.
Wow, okay. And finally, just a sobering note from some of the quality of care studies out there.
Yeah, unfortunately, studies do reveal fairly frequent lapses in appropriate follow-up testing and just documenting the replacement strategy clearly.
Some hospital systems found inappropriate management in up to, what, nearly a quarter of cases?
Something like that, yeah. Up to 24% in some studies. It really highlights a systemic need for not just knowledge, but rigorous documentation and sticking to clear unit protocols for electrolyte management. It's about execution and process standardization, too.
So true. Okay, let's talk prognosis. Generally, it's favorable if we manage this promptly and based on evidence, right?
Potentially, yes. But severe or persistent hypokalemia, that's undeniably linked to increased short-term mortality and predictably longer hospital stays.
And there's that clear U-shaped duration curve for hospitalization, too. The patients with the most severe hypokalemia, especially below 2.5, they have the longest stays and the highest readmission rates.
And crucially, getting the potassium normalized in a timely way really matters. Data shows that achieving normal kalemia, ideally by day 2 of admission in critically ill patients, is associated with measurably better survival compared to those who stay hypokalemic longer.
This evidence really brings us full circle back to that tightrope walk of management we mentioned.
Exactly. We now have solid data showing that both persistent hypokalemia failing to correct it and overcorrection that leads to subsequent hyperkalemia are associated with excess risk and bad outcomes.
It just underscores the absolute need for precision in our dosing and the most rigorous, frequent monitoring we can possibly do.
It's such a delicate balance. You're constantly trading the known risk of undertreating that potassium deficit against the iatrogenic risk of pushing the patient into dangerous hyperkalemia.
And this field, it still have gaps, areas for future work. We probably need more evidence on the best repletion protocols in really unique populations, like patients undergoing therapeutic hypothermia or those with really complex acid-based disorders.
Agreed. And the exact role of specific, maybe high-dose dietary interventions versus just relying on medication, that still seems like fertile ground for research, too.
Okay, so to try and summarize the core takeaways from this deep dive into hypokalemia management for everyone listening.
First, classify the severity accurately. Remember, below 3.0 millimoles per liter is a hard stop, needs immediate action.
Second,
differentiate early between renal and extrarenal losses using those urine potassium measurements. That really helps target your therapy.
Third, prefer oral repletion whenever the patient's status allows it. It's generally safer and easier if feasible.
Fourth, use intravenous potassium chloride cautiously. Stick religiously to the rate limits, use mandatory cardiac monitoring when indicated, and remember that 10 millimoles per hour threshold for needing central line access.
And fifth, the big one. Always check and correct coexisting hypomagnesemia. Correction will likely be futile without it.
Couldn't agree more.
So our final provocative thought for you, the listener, to maybe mull over and perhaps take back to your own unit discussions, is defining your personal and maybe your institutional safety margin for potassium, particularly in those high-risk patients, the ones with chronic kidney disease or the heart failure patient on digoxin.
Yeah, given that evidence linking both extremes, persistent hypokalemia and subsequent hyperkalemia to bad outcomes, that tightrope, where do you set your target? Should it be a more modest, say, 3.8 millimoles per liter, accepting maybe a small persistent risk of deficit to avoid overshooting? Or should you really push for 4.5, accepting that slightly higher risk of overcorrection, especially in someone with impaired renal function?
That decision, it really dictates how aggressive your replacement strategy is, how frequently you absolutely must monitor, and ultimately it impacts the safety and the outcome for your patient.
It's a complex, risk-stratified decision. And it really warrants ongoing internal discussion about your own institutional IV repletion protocols and what level of risk is acceptable in these high-risk scenarios.
Well said.
Managing acute electrolyte disturbances like hypokalemia is just foundational to excellence in hospital medicine. Precision in this area directly translates to better patient outcomes. Thank you so much for joining us for this deep dive.
My pleasure. Important topic.